My name is Jill Owen. I'm a pediatric physical therapist. I have been a PT for just over 12 years now, and I've been practicing in the pediatric setting for about 10 of those years. Recently, within the last year or so, I took the role of pediatric PT residency director at Ivy Rehab for kids. So I am now part-time in the clinic as a peds PT and part-time leading the pediatric residency program. So core stability or proximal stability or postural control, those things all kind of mean the same thing. It's really important for kids to have good core stability in order to really do anything more skilled or complex with parts of their body away from their core. So you can think about it as a fine motor movement too. Kids need good core stability to be able to write their name. Kids also need really good core stability to chew and swallow. And chewing and swallowing and breathing are arguably the most complex things that our bodies can do. So having a good, strong core, a good, strong base is really pivotal for those skills. A lot of our kiddos with low tone are notorious for W sitting, which is really hard on the hips and knees and just really doesn't require a lot from their core. So one kind of easy switch I like to make with those kiddos is putting them in some type of chair where they're in a 90-90 position, meaning their feet are flat on the floor, their knees and their hips are bent to a 90-degree angle, and they have some type of back or like postural support that they need just so they can maintain that good upright sitting position. Puts everything in a healthier, safer position. It's not putting any undue stress on any of those joints. So it can be a quick fix for that W sit position. Similar to talking about core stability, core strength, of your trunk or your neck, wherever it is along your core is super important when it comes to feeding. Again, kids need that good, solid foundation where they are strong enough to support themselves upright in order to really do anything more complex like feeding. So that strengthening is kind of one of the foundational pieces that kiddos with feeding difficulties really needs, and that PT can really help with. Kiddos who are doing any of those gross motor skills, whether it's the sitting, standing, or walking, are going to be put in a better position to not only interact with their AAC device, but interact with their peers. So AAC devices are really about, giving kids a voice, giving them the chance to communicate. And when a kiddo is able to sit upright and see and chat with their peers, or stand up and be eye level with their other standing peers, or walk over to a group of their peers and then initiate that use of their AAC device, it really just opens up a wide world for them. It really opens up that participation a little bit more. So super important for kids to have one of those skills to really better utilize their AAC device in a functional way. When a child has to devote less of their mental energy or less of their body energy to their standing balance or their sitting balance, or even their walking, coordination balance, whenever they have to devote less energy to those things, they can devote way more attention to detail, coordination, strength, endurance to other things. So if that is, using a pointer finger to more accurately touch a device to communicate, then their body can really use all of its energy for that particular skill, instead of also having to worry about keeping their body upright and balancing and not falling over. Kate is a really fantastic SLP who I work really closely with, especially in the residency program. And when it comes to really co-treating and working together in those sessions, we really play to each other's strengths. We each want what is best for the kiddo, in kind of our different respective areas of focus. So really just sort of respecting the process, respecting each other's strengths as it relates to wanting what's best for the kiddo, and just kind of listening to each other. We always play off of each other when we are positioning, when we're talking about communication, feeding, swallowing, breathing, all of that good stuff. So it really just comes down to, making sure that we have the same common goal, and we usually do, and then making sure that each of us has space to bring our area of expertise to the session with the kiddo. I'd say the biggest motor milestones that I look for in the first 2 years would be crawling, standing alone, and then walking. Usually in kiddos in those first 2 years, one of those skills is going to be really imperative to them being able to have access to their environment and interact with their peers a little bit better. So I would say that those are the 3 big things that I look for. When you work with kids, play should always be kind of at the forefront of your mind when you're in sessions. Kids play, and that's how they learn, that's how they develop, that's how they explore. So really making sure that they are engaged and having fun. I really like to bring families into my sessions. I think that, nobody really knows the kiddo better than their siblings or their parents. So families can always help kind of direct what direction the play needs to go in order for the kiddo to be having fun. And then, when you're incorporating peers or siblings, those challenging or those more difficult activities that maybe a kiddo is more resistant to at times, maybe it's not as challenging when you're, playing with a sibling and having some friendly competition or something like that. So play should always be the kind of most important part of your session. It's going to look different with everyone, but yeah, that's how you're going to get the best movement out of your kiddos. Anytime you can get PT involved early on and you can address posture, strength, endurance, alignment, whatever it is, anytime you can do that sooner rather than later, a kiddo or a person is going to be better off in the long run. I think we all know that kids are pretty spectacular and they heal really fast, their bodies learn really fast, they can kind of bounce back from anything. But that magic has a shelf life. So, if we identify something early on and we can address it early on, then, the problem shouldn't really be a problem later in life. That doesn't go, for everything, but I think it's a really good general rule of thumb. At Ivy Rehab for Kids, you are going to come across not only the most knowledgeable, best clinicians, but the amount that we all care about the community that we treat in is second to none. I mean, the energy, the time, the joy that we all get from seeing our kiddos both in and out of the clinic succeed is what drives us. So you will get not just a smart, skilled clinician, but you're going to get somebody who really cares at Ivy Rehab for Kids.
Hi, my name is Kate Dahlman. I'm a speech language pathologist. I've worked for almost 20 years now, all in pediatrics. I've been a part of the Ivy Rehab network since 2016. My current role, I'm the director of the Pediatric Speech Language Pathology program at Ivy, and also support enterprise-wide education as a part of the clinical excellence team. I actually have a lot of experience in feeding. I specialized in infant feeding when I was working in the clinic, and also both of my children had some feeding challenges when they were infants. So know a lot of this as a mom and a speech pathologist. I think, we tend to think of feeding as these picky eaters that we see throughout the community, but really it can start at infancy. We're really looking for that bond between like mother and baby, whether it's bottle or breast, how efficient that is, kind of what that looks like. Again, integrating the bonding, the co-regulation that can happen between mom, baby, caregiver, dad, whomever, supporting the family. Also sensory regulation, social routines. It even goes to where some of our other kids that might have some feeding challenges just want to be able to eat school at lunch. Or even be able to, have a birthday party and be able to eat cake and pizza with their friends. So really, it's more than just the food and encompasses all of those things as well. And even if we think of, holidays, family occasions, food is present throughout those. And so we really want the children that we see to be able to participate in their daily life and routine, whatever that might look like for their family. I think it's important to consider, as parents, we and the parents that come to see us in the clinic are the experts on their child. We're there to support as therapists. And so I think if they have a concern, whether it be, we can't get off a pacifier or baby's feeding all the time, we can't transition to foods with different textures. We do have a hard time where we're like very brand specific, like only like Chick-fil-A nuggets, things like that I think are important things to bring to your pediatrician's concern. And then as SLPs and then also occupational therapists are here to kind of help depending on some of those oral motor challenge that we might have. Even if we were just go back to the basic level of breathing and swallowing and eating, it's a very complex skill that a lot of us take for granted. And so if we see any hiccups in that, even in infancy and beyond, it can be a great time to talk to your pediatrician about some of your concerns. Absolutely. I have quite a few of these in my back pocket. When I was treating in the clinic, had a baby come in like 8 weeks old with a mom, having a really difficult time. That suck, swallow, breathe coordination was not there, having a lot of reflux because we were getting some air in. Mom was very stressed. Baby was very stressed. I did the feeding evaluation, noticed a few things, gave mom some support, and then pulled in my occupational therapist on staff too to help with some of that co-regulation, that bonding, that state control that baby and mom were having a difficult time with, and just be able to see the difference when she did some body work and got the baby a little bit more regulated, got mom more attuned to his things, and then we were able to work on the actual oral motor skills to where feeding was not such a stressful environment. The next time she came in, mom was calmer, baby was calmer, baby was feeding better. We don't think about this too, but when it's a struggle for babies and moms, they have to do it, a lot of times throughout the day, 8 at a minimum. So it was really a great representation of kind of the things that we can do and the difference that we can make. I think this is a great question. It's one that comes up often in the clinic, whether it's through augmentative alternative communication or sign language or a communication board. Really what we're looking for is that communication and connection. And research has shown across the years that any kind of alternative communication, again, whether it be gestures, pointing, anything like that, is really going to support the overall verbal communication. That's what we're looking for, is a way for these kids and these families to communicate with each other. It really does support rather than hinder that communication development. And again, communication can look different based on the child, the diagnosis, age level, family support systems, caregiver support systems. We're really just looking for a way for them to interact and participate in their daily life. And so to be able to do that, I think we tend to focus a little bit more on the verbal side of things, but we all communicate now with emojis, text messages, so many other ways to communicate. So I think when we kind of can take that lens, you can really see that it does kind of help support communication overall. So I think this is important too, to kind of consider not just the age of the child, but where they are developmentally and where their communication skills are. As pediatric speech language pathologists, including OTs and PTs as well here, we really have to kind of go in and be detectives and figure out what these children are into. So are we into Bluey? Are we into Coco Melon? Do we love the Five Frogs song? Really try and build off of their interests, to where we can kind of put some of these things. We have the ability to program these devices to where they have the things that they're interested in. Like us as adults don't really want to talk about the things that we're not that interested in sometimes. And so even for some of our little patients to come in and be able to, select that they want to talk about Bluey, or even if we program a phrase that they're really into, a lot of our kids that will use AAC also develop language in some different ways. And so we're able to kind of program some of these phrases, some of these songs, really whatever they're into. We're really looking for that bonding moment and building trust with them. And so we really have to figure out what they're into, again, be that detective. And that's kind of what we can do to kind of facilitate their communication, engagement, and overall interaction. So typically what we like to talk about when we talk about care over the home environment is we're trying to think about things that are already happening in their daily routine throughout their daily life. And I think even as SLPs, we tend to focus more on the requesting aspect of alternative communication. So say you want goldfish, you go and hit the goldfish button. But really, I think what parents, caregivers, and other therapists can do is you really need to model that language the same way we would verbal language without any expectation, to just kind of model what we're doing as a part of our routine. If it's reading books, if it's playing with blocks, if it's blowing bubbles outside, just really something that we're doing. And again, we're just going to model it without the expectation that they are going to go in and communicate back with us, because we would do the same thing verbally, just when we're trying to teach children to talk. It's the same idea, just a different method of communication. So this one I think varies a lot depending on the age of the child and other concurrent diagnoses that we might have at the same time. I think what we really look for as SLPs is kind of where they are and we meet them there. So are we pointing? Are we gesturing? Do we have any eye contact? Or what we're really looking for outside of eye contact and no intention is just that engagement. So do we have that ability to build that relationship, to grow that trust and then grow that connection? Again, some of the early ones that we would look for would be pointing, gesturing, making sounds. But really, again, we're just trying to meet them where they are, support them where they are, build up their strength. And then if you think about like a rubber band, we're just going to kind of stretch their strength to get to the next one. So a lot of what we do in and out of the clinic as SLPs, we're really trying to focus on that play-based approach. Again, that's where children are going to learn the best. Their job as a child is to play, right? That's their favorite occupation. So really what we are trying to do is then work on getting our goals into that playful setting. So again, picking up things that the children like to play with, their favorite topics, their favorite toys. Trains are really big. We have a lot of Thomas. We have a lot of Bluey again. A lot of animals that we're playing with, and we really can kind of fit these activities into what we're doing. So a puzzle can become a turn-taking game. We can work on, some easy prepositions with, like a Fisher-Price barn and some animals, putting them in, taking them out, work on actions. So it's really, we can model throughout as we're doing these play activities, again, with those meaningful goals and skills that we're trying to build, but really just make it what they're into, what they're going to respond the best with. And again, building that connection where we're just all having fun together. That's really what we're trying to do. I think if we think about carryover to home, right, we really need to kind of zoom out on what we're doing. I think us as therapists get very focused on what we're trying to do within these four walls of our clinic. But, as a child and a family, we really want to support them outside of the clinic. So again, what is important to them is kind of where we're going to work on some of those communication skills and that carryover. A lot of times we go back to routines and their daily things that they're already doing. So we're not trying to add something on to their daily routine, because we all know we're all busy from the moment our eyes open till they close at night. But what's already happening throughout their day that we can give them a little extra support. If we have families that going to Target is stressful, can we help them with a routine to where we can give them some visuals? So, we can get in the car, we know we're going to Target, we know what's next. If it's bath time and that's stressful, how can we help facilitate that at home? Again, something that they're already doing as a part of their day, that we're just going to kind of work on getting some of those skills in a different environment.
Hi everyone, my name is Brittany Bosley. I am a pediatric occupational therapist by trade. I have been with Ivy since 2019, where I started as a staff clinician. I then quickly moved into our regional OT role, and then in 2021, I was tapped on the shoulder to start our pediatric OT residency program, which I still run to this day. And currently in my role, I am out of the clinic. I work on the clinical excellence team on the support service side of things at Ivy, on the background, helping support clinicians with continuing education and enterprise-wide initiatives such as our clinical career ladder. As a pediatric OT, when we meet a child or evaluating a child who is struggling at mealtimes, we really start by observing how they are sitting, moving, and interacting with their environment around them. So we can be looking at their posture. Are their feet supported? Is their body stable in their chair? And then I'm going to be starting to look at their hands and their mouth. Does it seem hard to pick up a utensil and bring it to their mouth? Or do they seem overwhelmed by the smells and the textures and the sounds that are around them? Sometimes kids will give nonverbal cues, such as turning their head or gagging or avoid touching certain foods. And that really clues me in to the fact that a sensory input is a big factor here. Other times they're just working so hard to sit up straight to eat that it becomes exhausting. So you really really have to have core strength, so that proximal stability, before you have distal mobility. And so what that means is you have to have a strong core before you're able to focus on other things such as eating. And so it's like being a detective. You're piecing together what is happening underneath the surface. There's so many small little things that parents can do at home right away that make a huge difference. One of my favorite things that I can recommend is giving a kid a footrest at the table. So like a stack of books, using those old textbooks, or even an Amazon package under their feet can be such a game changer. It can make them feel more secure and help them to eat better at the table. A stable body helps free up their energy for the chewing and utilizing utensils at the table. For utensils, I would say chunkier handles, so like small, chunky handles, toddler-sized utensils or cutlery can help them grasp better. And then even trying like a divided plate to reduce the overwhelm if your child is sensitive to food touching. And then don't underestimate the power of turning off distractions. So turning off the TV, dimming the lights, all of these sensory modifications can help a child sit at the table and interact and enjoy that dinner time. This is one of my favorite parts of working on a team and so closely, and Ivy really champions interdisciplinary collaboration. And so feeding is the perfect component or the perfect topic to talk about interdisciplinary collaboration, because feeding is never just one thing. If a child is struggling with oral motor concerns, such as like they can't manage chewing, or they tend to pocket food in the side of their cheek, I'm going to loop in Kate, who's one of our speech therapists. We'll meet and we'll align on goals and make sure our strategies complement each other if we're both working on different things with oral motor skills. Same thing with Jill, who is one of our PTs. If a kid's posture is making it really hard for them to sit at the table, I'm going to bring in Jill to help work on some trunk stability and maybe even provide some adaptive seating. We each bring our own scope or lens to the table, but we're constantly talking and interacting about each child or case, and then so that it seems like one seamless plan for the family. And we really just want them to go home feeling like they're supported across all disciplines. I think, again, it goes back to the support, right? So often clinicians are siloed, their discipline, and all they focus on is their own little niche bucket. But at Ivy, it's such an interdisciplinary collaborative approach that it doesn't feel like you're siloed. You're constantly interacting, engaging, collaborating with your teammates to provide that best care for that child. So it's a really great opportunity to always continue to push yourself to grow, as well as learn about the other disciplines that you're working alongside of every single day.